It's right at noon Central Time, so we'll go ahead and get started. Thank you everyone who's joined us. My name is Larissa DeLuna with the American Heart Association, and I'm happy to welcome you to the American Heart Association Stroke Webinar Series. Today's webinar will focus on a model for statewide rural outreach for hyperacute stroke treatment. These are educational webinars that are brought to you by the Southwest Affiliate Stroke Committee. All of these webinars, past webinars, are posted at our website, heart.org/SWA quality. Before we get started today, I'd like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. For questions, you can unmute your line by pressing *6 to type in, or you can type into the Q&A section of WebEx. Although this event is not accredited for CME or CE credits, attendees will receive a certificate of participation as proof of attendance. All slides, handouts, and participation certificates will be sent to attendees within 1 week of today's call. We're happy to have two guest speakers today, Dr. Margaret Trimwell and Renee Joyner. Dr. Trimwell is a stroke neurologist and the medical director of Washington Regional Medical Center's stroke program in Fayetteville, Arkansas. She is also the chair of the American Heart Association's Southwest Affiliate Stroke Committee. Renee is the director of operations for Arkansas SAVES, a Medicaid-funded statewide telestroke program operating through the Center of Distance Learning at University of Arkansas Medical Sciences. At this time, I'll turn it over to them.
Good afternoon, this is Renee, and I think that Dr. Trimwell is going to join in as we go through the slides. I'm very excited to be here today to talk about SAVES, which is a unique telestroke program that we have in Arkansas. And let's see, Larissa. Okay, there we go. So I have nothing to disclose. Our objectives for today's presentation is, one, to describe why a coordinated system of care is needed for stroke patients. That includes a telemedicine component. To describe how the Arkansas Stroke Assistance through Virtual Emergency Support, which is SAVES, is providing access to vascular neurologists and evidence-based treatment of acute ischemic stroke in Arkansas's most rural communities. To present the impact of a comprehensive telestroke program on patient outcomes over time, and to discuss the cost savings of a statewide telestroke program. Our motto here at UAMS with the Centers for Distance Health is one we kind of stole from Bono, and it is, where you live should not determine whether you live or whether you die. And you'll understand why we're saying that more here in just a moment. So it's important to know what telemedicine is, particularly from a Medicaid perspective, in order to be reimbursed. So the Medicaid definition is it's a two-way, real-time, interactive communication between the patient and the physician or the practitioner at the distant site. The electronic communication means the use of interactive telecommunications equipment that includes, at a minimum, audio and video equipment. It does not mean, Marisha, if you could do the next one, please. It does not include email or web page data collection. So we've got a question for the audience. Have you ever used telemedicine in your practice? Yes or no? And I'm not seeing any responses, but we'll go on to the next slide.
So 14 out of the 43 people attending said yes, 10 said no, and about 2 were not sure.
Okay, great. Thank you.
Let me close the poll. All right.
So So the reason why telemedicine is important in a rural state is this: access to subspecialty health care. And telemedicine can actually enhance rural economic development by being able to provide the providers at the ED, in the home hospital, in the community hospital. It also allows for patients to remain in their community, and then the community receives the market share of resources. So there's a lot of different advantages to having a telemedicine program statewide, both for the providers and for the patients, and also for the community and for those that reimburse, the third-party reimbursers. There are several different kinds of models of a telemedicine program. One is a closed system but open to all hospital networks. That's SAVES. We operate out of UAMS, but because we're Medicaid funded, then we're considered a gap filling program. And so any hospital that doesn't have access to vascular neurologists can join our program, no matter if they're Baptist, St. Vincent, whatever network they're in. And within a closed system, there are two different types of telemedicine. With SAVES, we have the type where there is a physician-patient relationship, which means that all of our physicians do have to be credentialed in each hospital where they provide a consult. Or we have the Arkansas Trauma Hand and Burn telemedicine program. That's a physician-to-physician consult where there's no patient relationship, and therefore they do not have to be credentialed in every single hospital. There's a closed system within a hospital network. Our Mercy Health System here in Arkansas is an example of that, and it's pretty much and the VA system too. They kind of take care of their own. So they have a telemedicine program, but it's within their own system. They use their own providers, and if a smaller hospital cannot take care of a post-TPA patient, then they transfer within their health system, and it works beautifully. And then there's another kind that's really coming on the scene right now, which is where rural hospitals can contract directly with subspecialty providers. The University of Mississippi Medical Center is an example of that. Their ED physicians train nurse practitioners in about 5 or 6 very rural hospitals in order to provide emergency care in those facilities. Otherwise, those facilities were going to have to close down. So that's kind of a unique model. And then there is a model where a hospital can contract directly with a group of subspecialists, such as Neuro-on-Call. It's a group of specialists, and what they do is provide the consult, but outside of that, I mean, that's really the only piece that they provide. And then there are companies that provide a turnkey service, such as One Touch or Reach, and that's a company where they provide the connectivity, the equipment, the specialist, the software for the data analysis, the entire piece of it. But what we're going to talk about today is SAVES and the number one, the closed system, but open to all hospital networks, and how that works. So Arkansas, you guys may know this by now, but Arkansas was number 1 in stroke mortality. We're in what's called the stroke belt. We were first in 2011. We're excited to say that we're now 6th in the nation in terms of stroke mortality, and we're hoping to move further down the line on that. So Arkansas is, let's see, it's a beautiful state to live in, but it is a difficult state to get from area to area. And so you can see that we've got 2.9 million in terms of the population who lives here. Of that 2.9, 50% of our population lives in what is defined as a rural area. And 54 of our 75 counties are considered rural, which means that they have less than 50,000 population. In addition to that, we have the 12th largest road system in the nation, and very few of that is actually interstate. So to get from one location to another, it can be difficult. Also, Arkansas has 73 of 75 of our counties are considered MUAs, and so there's no access to primary care either. So the way that this all started, AR-SAVES started, is back in 2002, the Department of Human Services, the Medicaid Division, approached UAMS with a high-risk OB support concept. And this was an initiative. This was an initiative to look at high-risk infant mortality, and we were one of the highest at the time. And so the Centers for Distance Health developed a concept for telemedicine. Medicaid was able to leverage federal dollars to increase access to care. UAMS actually provides the state match to that. So there's really no state funding that goes into the program. This is the model that AR-SAVES is built on. It's 100% Medicaid funded. Medicaid pays for the on-call cost of our vascular neurologist. It also pays for connectivity to maintain connections and equipment. And we also are able to offer to the hospitals in the system FTE support for a part-time nurse and a part-time IT support person. So connectivity is a big issue with telemedicine. Back in 2006, actually, the Department of Health had bioterrorism funding that they used to put T1 lines connecting every hospital in the state and to put Tanbergs in every emergency department so that in the event of a mass casualty or any other kind of disaster, if there is a need, hospitals could communicate to each other and then back to the Department of Health. This was built on, and this infrastructure was used to leverage additional monies from the SEC Rural Healthcare Pilot Program. And you can see on this slide that in 2007, they were able to get a $4.8 million grant award, and then 2010, an additional $102 million grant award. And so now what we have is an incredibly connected state as a result of the grant funding that we were able to get. If we'll go to the next slide. So you can see on the left, this is how Arkansas was connected before 2010, and now you can see how we're connected today. There's over 625 sites connected. We've had over 160,000 hours of video calls. So we know that it works. We do it all day, every day. We do it for a lot of different reasons. These connections here, the dots, represent our critical access hospitals, our acute care hospitals across the state, all the hospitals that would otherwise not have access to a vascular neurologist. Next slide, please. So does it work in terms of the money that's being spent on it? We had experts take a look at how much Medicaid was paying and the cost savings of the program in calendar year 16. So in calendar year 16, we had 247 patients treated within 3 hours of their last unwell time. 115 of those patients made a complete recovery, which I think if you do the math, that's like 46%, I think. Y'all may have to help me with that. But anyway, so if you look at the projected savings in healthcare costs as a result of those 115 patients making a full recovery, the net savings for the state was $27 million, over $27 million. I feel like that's a very conservative estimate. It doesn't really include long-term care for patients had they had bad outcomes. And as you can see, our annual budget is $9 million. Next slide, please. So in order to make this successful, There are lots of different components to the program. So we talked about the connectivity and the equipment. We have a 24/7 call center, and all of this is funded through the Medicaid contract. We have a 24/7 call center so that once a stroke patient enters the ED of a rural hospital and they suspect stroke, they immediately call our call center. We take a limited amount of information from the ED staff, and then we connect with the vascular neurologist to complete an assessment. So that 24/7 call center is an important component to the program, and it's a component that I've not found in other telestroke programs, and I think it's one of the reasons why we're as successful as we are with our program. The second reason I think we're so successful that I've not found in other telestroke programs is the video support. So we have IT specialists who are on every single live call to make sure that there's no issues with connectivity. And if there are, then they're on the phone with AT&T or Windspring or whoever happens to be the provider for that hospital to make sure that we get that connection back. They also kind of watch the carts 24/7, so they know if the cart has been unplugged, if it's online, if it's not. They'll make a phone call to the hospital to say, you know, if you need a DLI call, it's not gonna work. You're gonna have to get your cart plugged in, whatever the issue is. But they troubleshoot those sorts of issues. We also have an image repository. This is where the CT scan that's done at the originating site can be immediately uploaded into a repository so that our neurologists can have immediate access. So we're not having to wait for their radiology department or whoever reads their CTs to make a read and then get that information to the neurologist. Our neurologists can do that themselves, and it's immediate. And then we have our contract neurologist. We are bringing all of that into the state. There for a while we had to have a few that were out of state, but now we've got enough where we're going to have Arkansans taking care of Arkansans, which we feel like is real important. And like I said, we've got a 24/7 call list. We have a backup neurologist in case we have more than one call at a time. I talked a little bit about the funding for the hospital participation earlier. That funding also includes workforce development funds. So we provide funding for each hospital so that they can attend any trainings that we do or any other trainings that would support their staff in providing better stroke care. And then we also do data, which we're going to look at here real quick. In a minute. For quality assurance, we do QA on every live call that's conducted through AR SAVES, and we provide an email, a friendly email back to the ED to say, y'all did great here, here are your opportunities for improvement, and here's some training that's available to you to improve for the next time you have a call. Some of these small hospitals may get one call a year, and so we make sure that they're kept, you know, their skill sets kept up. They're required to do at least a mock a month, and that helps. And then we do on-site visits where we can provide training. We can look at their time targets. We make sure that they've got the evidence-based protocols in place for their facility, those sorts of things. The other thing that's really important about AR SAVES is community outreach. You know, we know that you can have the program, you can have the best care available, but if the community doesn't know that it's there and in their local hospital and what to look for in terms of signs and symptoms, they're not going to be able to get to the ED in time for treatment. So we spend a lot of time and effort. Each hospital is required to do at least 2 community outreach events a month through the Medicaid contract. Next slide, please. Okay, so this is St. Mary's, which is an acute care hospital, and this is Tim Tanner, who is a nurse facilitator for that program, and he's actually conducting a mock right now with our call center. And so if you're in the ED in one of our facilities, this is what you see. There's our cart, and who you see on that other screen, if they weren't doing a mock and it was a live call, could be Dr. Trimwell instead of Calvin. But that's what it looks like from the patient's perspective. Next slide, please. And then this is what the vascular neurologist will see on the other end. It's important to be able to make sure that we're given the right medication, that we're given the right dose, that the bolus amount is correct. And so all of that is shown to the vascular neurologist as a confirmation. And it's as clear as that. That's what they see. Next slide, please. This slide has a lot of information on it, but it shows Arkansas and our 75 counties, and each red flag represents an AR-SAVES hospital. We've got 54 hospitals across the state that participate in the program. We're hoping to bring another 6 hospitals on this next year. And once that happens, every ED in the state will be a stroke-ready hospital. And so we're so excited about that. When we combine our efforts with the Mercy Telestroke program, with what's happening with the VA and St. Vincent, then every single ED in the state can provide treatment, on-site treatment to stroke patients. You can see that in calendar year 2017, we had a total of 1,002 consults. We gave TPA to 340 patients. And so our percentage of patients treated with TPA is 34%, which is very high considering some other programs. And then we did a total of 1,004 mocks. With our community events last year, we did over 1,700 events, and we were able to reach out to over 289,000 Arkansans. So, and then you can also see that out of the 54 sites, 20 of those are critical access hospitals. That's the whole reason the program was developed, was for those sites. And then by December 2018, we were looking to have 23 critical access hospitals. We're doing right now 3 to 4 live calls a day. What's on the bottom is also important. We're not bringing every post-TPA patient or patient that needs interventional radiology to UAMS. That's not what the program is about. And so what we've done is to identify the hospitals across the state that have neuro ICU capability that can take a post-TPA patient, and those that also have interventional radiology. We want the patient to go to the closest, most capable hospital possible. It's important to us to be able to keep the patient as close to home as possible. Next slide, please. We're really excited about this slide. This is a 30-minute drive time to a stroke-ready hospital once we get all the EDs in place. The blue circles are what's currently in place, and then the yellow circles are the ones that we're going to bring on during this next year. The green circles that you see on here are the Mercy sites. So that's the best that we can do. We've got a few holes there, but there are no hospitals in those counties for us to bring on. Next slide, please. So a question for the audience. Do your pre-hospital providers know the location of their closest stroke-ready hospitals? Yes or no? Okay, so it's showing that 27 out of 47 do, none out of 47 no, and then not sure 19 out of 47. This is an important question. Next slide, please, Felicia. For this reason. So since 2008, we've been collecting data, and so we're data rich right now, and we're really trying to drill down to see how we can improve the program and what we really need to be focusing on. And so we've been looking at patients that arrive to our stroke-ready hospitals by EMS or by TOB. And for those that did arrive by EMS, did EMS pre-notify that they were headed to that facility with a potential stroke patient? And so in 2017, we had 1,002 stroke patients. At the time, we had 48 hospitals. We've brought some on since then. Those arriving by EMS decreased the door-to-CT time by 4.7 minutes versus those that came in by POV. That really kind of surprises me. I expected that to be a little bit better, but still 4.7 minutes. And then EMS alerted ED with code strokes. Those that did decreased the door to CT time by 11 minutes and 4 seconds. That's huge. But those that arrived by EMS with pre-notification, we saw a 29-minute reduction in door-to-needle time. So what we're trying to do is to get the word out to everybody. Call 911. Here are the signs and symptoms of stroke, and then call 911. Do not bring your family member or your friend in by your car. Call 911. And then we spend a lot of time training our EMS providers, signs and symptoms of stroke, where their stroke-ready hospital is at, and to be sure to pre-notify code stroke before they get there. That way, if there is a patient in the CT, they can take that patient, remove that patient out, and have the CT ready for the potential stroke patient that's coming in by EMS. Next slide, please. So what is the average drive time for EMS to reach a stroke-ready hospital from a rural area in your state? A is less than 30 minutes, B 30 to 60 minutes, C 60 to 120 minutes, and then D more than 120 minutes. Okay, so we've got the results. A, less than 30 minutes, 15 out of our 46 participants. 60 to 90 is 3. 90 to 120 minutes is 4, and then not sure is 20 out of 46. So this is kind of our dashboard that we look at. So 37% of our patients had a door-to-needle time within 60 minutes. Of course, that's our target. We try to meet the AHA targets and guidelines for our care. Last year, or for FY16, it was 26. So we have improved quite a bit this past year. This compares to 26.6% of hospitals with a neurologist on site, and it's better than other large telestroke programs at 13%. So not only do we compare ourselves against ourselves, but we also try to look at the research that shows some data on a national level. The two charts below shows shows the number of consults and then the number of patients that receive treatment throughout our time, and then the percentage of patients that receive treatment is the one on the right at 34%. Next slide, please. So this really says it all. This is a case study of a patient that came into one of our hospitals in Searcy and had a complete basilar artery occlusion or brainstem stroke. A brainstem stroke, as you guys know, is difficult to identify. It's not, you don't see the usual fast signs and symptoms. But we've been really educating EMS on BFAST. We've added the balance and the Oz to the list of signs and symptoms. And EMS arrived on scene. This was a 49-year-old fireman with a history of AFib, not on anticoagulation. The patient became ataxic, drowsy, speech heavily impaired, vomiting, severe nausea. North Star EMS brought the patient from home to White County Hospital in Searcy in Arkansas. So his initial NIH stroke scale was 11. His time of onset was 11:55. Case conclusion is he left the hospital in 4 days with an NIH stroke scale of 0. The cool thing about this is this patient won. When EMS arrived on scene, they knew what they were looking at, and then they pre-notified and got the patient to the closest stroke-ready hospital available to them. They arrived on scene at White County, so last unwell time to the ED was 37 minutes. They were seen by the ED medical director within 7 minutes of the time that they got there. We got the neurologist connected within 33 minutes. This happens to be one of Dr. Trimwell's patients. And then we were able to give alteplase within 46 minutes from arrival into the ED. This patient was transported by air to UAMS and arrived at UAMS at 14:20 and coded. Almost as soon as they got into the ED, he coded. But he and was intubated at 14:25. They were able to revive him and remove the clot. He went to interventional radiology. They removed the clot at 15:18. And so from the time that he had his first symptom to the time that he left or was cared for at UAMS with interventional radiology was less than 4 hours. And before we had this program, there is no way that that could have happened, and I believe that this patient would not be alive today. I don't know, Dr. Trimwell, if you want to make any comments about that. Okay, well, we'll go on. You'll see on the care team, we've got North Star EMS ground ambulance. We've got the White County Emergency Department staff. We've got AR SAVES who has to do the connection between the ED and our neurologist. Survival flight air ambulance then arrived at the White County Emergency Department to then airlift them to UAMS. And so there was a lot of things happening in order to take care of this patient, and it just went very smoothly.
I'm sorry, I had trouble getting my mute button to work right. This is Trimwell, and yeah, I just want to emphasize that when you look at this case, this is not just a one person in 8-10 years. This is a routine phenomenon that we find. And also to emphasize that stroke does occur in the young, and my personal experience is a young person in a rural area has a good chance of doing well if we can just support the blood vessel circulation that they have that's patent, try to dissolve the clot as much as we can, but more importantly is the TPA keeps the collaterals open so that we give the TPA, they're getting the helicopter at the same time, the patient's taken into a place where they can pull out a clot, that they have an excellent chance of doing very well with a full recovery or near full recovery. And the other thing is that in this thing, it's not like you have to do every single component of this, that once EMS sees what their impact is on a patient, then all of a sudden they're asking for education. They're bringing questions. They're actively involved. And the same thing with the nursing and physician staff. that always in the beginning there's always a little bit of fear with change, but once they start seeing that the impact that they're changing their practice has on their community, then everybody's all in. I think Arkansas SAVES is probably the most popular program in the ERs across the state. And the ER physicians would say that when a stroke patient comes in, that's the easiest thing that they do because they know they've got expert care that's going to take care of this patient. They got a system of care within the state that's going to make sure that they're in the best spot that they need to be to make a full recovery. I can't recommend a program any more highly than this. It's worth the effort of organizing people because they're going to organize themselves, you know, as you go along.
And that's exactly what we're seeing. So I think that when we first started, we were begging hospitals to come on board, and now we've got hospitals begging us to get on board. And so we've had to go back to Medicaid to ask for additional funding in order to bring on additional sites. Like I said, initially it was for our critical access hospitals, but now what we're trying to do is make sure every ED in the state is stroke ready. So Tim Vanderverse, one of our outreach nurses, he's also a paramedic, and he does all of the training with EMS. And his calendar is booked with EMS agencies calling him and asking him to come out and train their medics. So Dr. Tremwell and that's exactly right. On the next slide, you'll see how we've done since 2008 in terms of our time targets. And so we're steadily trying to improve. We're really trying to get down to that 60-minute door-to-needle time. And like I said, we do on-site visits to every hospital that participates with us, and we really look at how they can shave off a minute here, and how we can help them do that. So that kind of shows the improvement over time. The next slide shows kind of how we do our on-site training. Like I said, we train, we retrain, and we train again. It's important for the nurses and the physicians, the ED physicians, to be comfortable with the equipment, with being comfortable being on video, and then being comfortable with helping the neurologist do the NIH stroke assessment, the scale. And so we do mocks and make it very, very interactive for those sites.
There's the annual, oh, you're going to do that one now. I'm sorry.
And then here's our annual training or convention. Did you want to say something about that?
Well, what I would say is with the annual training that we it's a stereotyped exam that the nurses are taught for evaluating the stroke patient, but at the meeting, we interact with one another and present different cases which required different types of evaluation, and we can all learn at that meeting so that like the Basler stroke patient requires a little bit of a different exam to be able to get the data, you know, what's wrong with them. And so we can learn that as a big group together, so everybody skills are lifted up at this meeting.
We're having our annual conference this week. As a matter of fact, it starts tomorrow, and we have nearly 300 physicians, ED nurses, and EMS practitioners come into the conference this year. And so it's just an incredible time to bring everybody together, let them learn from each other. We are going to be doing hands-on skill stations with difficult patients, the scenarios from the ASLS class. So we're looking forward to that. Next slide is, do your stroke-ready hospitals conduct community educational activities on the signs and symptoms of stroke? And then do they call 911, yes or no? And while we're getting answers to this, I'll just say, you know, like I said before, we believe community outreach is as important as clinical excellence in the program. And so we spend a lot of time and effort working with our hospitals on how to do outreach in their community, how to identify high-risk communities within their community, and how to reach out to them in order to get patients into the ED in time for treatment. And we've got some evidence that shows that with community outreach, if it's with large groups and it's interactive, we do see within a time period patients coming into the ED in time for treatment. So we know that it works. So on the poll, do your stroke-ready hospitals conduct community educational activities? 18 out of 47 said yes, 3 said no, and then 26 we've got no answer for. The next slide shows the largest brain in Arkansas, and it's the only, there's not anybody else in Arkansas that has this, and it's beautiful because it's a great tool to start the conversation. And so we take this to community events, and as you can see here, this is an elementary school. We've really started trying to get into the schools because, you know, many of these kids go home to their grandparents, and the person who's having the stroke is not going to necessarily know that's what's happening to them. So it's important for those around to understand the signs and symptoms. So we've been spending a lot of time and effort with elementary, junior high, and high school. We actually won the RAISE Award. It's the National Stroke Association RAISE Award and for our community outreach last year. So we were excited about that.
One example of that in a local area was getting health teachers on one specific day. I think it was the 4th of May, and they called it "May the Force Be With You" to end stroke. And the health teachers taught their students. I think it was 2 grades, 6th and 7th grade, and then charged those students to go home and teach their parents the signs and symptoms of stroke. And programs like that really get the kids enthused. They love teaching people things, and it's a good way to get the word out.
So the slide that you're seeing now, we do a big Strikeout Stroke as a community outreach event, both in Northwest Arkansas and in the Little Rock area. And so this is our Strikeout Stroke for this year here in Little Rock. And you can see we recognize our stroke survivors at these events. And so everyone that's on the screen except for Olivia to the far left are stroke survivors that we're taking care of in our program. The gentleman that's on the mound raising the ball and who threw the very first pitch is the 49-year-old fireman that we just talked about. And it was really incredible to watch him be able to throw the ball. He didn't quite make it over the base, but he did a good job with that first pitch. So that just kind of brings everything back around to this is why we do what we do, saving patients one patient at a time. Next slide, please. And then this is why it works. These are our nurse facilitators from across the state. There are 54 hospitals represented in that group. We have a nurse facilitators retreat in addition to the annual conference where we just bring them in and we do roundtable discussions on what works in different sites and what they need from us that's different than from what they're getting, and what our goals need to be for the next year. And then the next slide. So this is one of our stroke survivors, and I'm showing him because I'd like to read a quote. He's Tom Berryhill, and he was taking care of it at St. Mary's. He should have gone to Dardanelle, but at the time, Dardanelle was not one of our hospitals. Now it is. Because of him, Dardanelle reached out to us, and we've been able to bring them on as one of the sites. But I called Tom and asked if I could talk about him in my presentations, and this is kind of what he said back to me. He sent me an email, and he said, "I'm curious, do you ever do anything to recognize the various members that play a part in AR SAVES. Let me see if I can find this. Okay. All I did was refuse to die until the doctors intervened. What about the paramedics, the ER staff, the nurses, flight crew, the ICU staff, and everyone else? Those men and women are the rock stars of the program. I'm just the lucky recipient of their talents. I would hate for those people to ever be taken for granted. They're very special to me, and they're the reason that I can say thank you and Merry Christmas. Tom Berryhill. So he's going to be at our conference this week, and we've got a survivor panel that kind of tells their story, and it's an opportunity for him to kind of say what it's like being on the other side and to be able to say thank you to the group that took care of him. And then we were going to try to do a video, but I'm not sure, Larissa, if that's going to work.
Let's give it a shot. 1 sec.
Okay.
Are you able to see my screen?
Yes.
Video coverage with neurologists from UAMS. Hey, promoter, can you raise your left leg? I'm told I can. Just my left leg or my left side functions working very good. Oh, that's what I got. Well, I can remember I had droopy face on the left side. I was slur speech. Okay. Okay. The left facial group. Went to me on TPA. He has a blood clot in his brain, and this medication may dissolve the blood clot. A shot apparently to help my symptoms. At the time, I didn't know it was a stroke, but apparently I had a stroke. If you get this medication, you have 1 out of 3 chances for complete recovery, for major improvement. Whatever that medicine was, it worked very, very good on me.
Okay, great. So that was one of our very first patients who received TPA. And what you could see on the screen at one point, you could see him, but you could also see our call center in the bottom corner, our video support person, and our vascular neurologist. And so it takes all of them to make a live call possible. And I'm happy to take any questions, or Dr. Trimwell, if you want to add anything.
No, I think you've covered it all. Any questions from the participants?
Yes, so there's one in the polling in the Q&A section. Does our AR SAVES coordinate all the community and outreach events and education?
So the way, no, we don't. It's actually the responsibility of each hospital to do that, but we provide, we're able to use our funding to purchase swag, so we have magnets and fans and pens and brain erasers and everything else you can think of, and so we provide those free of charge. And we use BFAST, that's the term that we use. We provide those free of charge to all the hospitals. Now, we do often go out and assist with those events because, like I said, many of them are so large that they can't really do that on their own. If they use the MegaBrain, then we are there with the MegaBrain. We have to bring that to them, set it up, and then bring it back.
And the information is in multiple languages. We even have up here information in Marshallese from Arkansas SAVES.
Wow, that's great. That's the only other question I had in the Q&A section. Would anyone like to come off mute with *6 to ask a question? As everyone gets up the courage, I'll also just put out a few reminders. a copy of the presentation, and then the recording and the certificate of participation will be ready for everyone in about a week. And that'll be emailed to everyone who's attended and registered. Any questions with star 6? Anyone would like to come off mute? We did have another one come in through the Q&A section. Do you have competition in your state with comprehensive stroke centers? We currently have 3 different systems providing comprehensive treatment. All systems obtain rural transfers, and this is a large portion of the stroke patients treated.
Well, currently we don't have any comprehensive stroke centers in the state of Arkansas. And I wouldn't call it competition. We have a lot of cooperation. Our SAVES helps determine where the patient should go, and it's based on the shortest time to get the appropriate care.
And that builds on a trauma system of care that we were able to get funding back in, oh gosh, 2011, I think. I can't remember exactly. For the Department of Health to set up a trauma system. And, you know, we only have one adult level 1 trauma system in the state, and that's in Central Arkansas. And so there's a call center that's been formed for EMS to call when they get on scene of a trauma patient and call this call center to say these are the injuries, where's the closest place for me to go. In order for that to happen, we had to bring all the hospitals together to work together, and we had AR SAVES already in place when that started. And so like Dr. Trimwell said, there's just an incredible amount of cooperation across the state to get the patient to the closest place that can take care of them. It's really an incredible system.
Well, you've inspired several other states. I'm seeing comments of people who are wanting to get this built in their state. And we did get a question. I mean, do you mind sharing where you got the big brain from? We got a question on that.
Let me send you that information.
Okay.
It's somewhere in Texas, but yes, I will send you that information.
Okay. We did get another question. What's the optimal time frame for thrombectomy post-TPA?
Well, now the time window extends out to 24 hours for the possible time window. The optimal time window is certainly within the first 4.5 hours. Any measure you can use to improve the patient's perfusion of their brain is acceptable in the first 4.5 hours. Beyond that time window, there's a few studies that are out there. One of them looks at CT angiography and then CT perfusion to determine if there's an area of brain that is at risk of being lost but is not yet lost. It's just ischemic but not deceased. And so if you pull out the clot, there's a good chance that there could be a good recovery. And then another study that just looks at the size of what we call the core infarct, and that's the area of brain that by CT perfusion looks to be already lost, that there's no recovery. And if that is small enough, then the idea is, and you have a NI-stroke scale that's greater than 6, then pulling out the clot, there's a good chance that you can have improvement in the patient's outcome. And that extends out to, in one study, out to 16 hours, and the other study out to 24 hours. So currently in the state of Arkansas, we're looking at 24 hours out for thrombectomy. But the issue is there's only a few thrombectomy centers in Arkansas. So we also have to take into account, you know, the length of time it would take for the patient to get to a thrombectomy center and how severe the stroke and their age, you know, greater than 90, the chances of doing well are, of course, less. So we look at multiple factors in this.
What data do you require when a patient has been treated at a facility with TPA?
I'm sorry, I didn't hear what you said.
What data do you require when a TPA patient has been treated at a facility? I guess when they're transferring?
Oh, well, a report is a nurse-nurse report, and then a physician-physician report is given. And what I'd like to know is just when the last known well time was, what the symptoms are, what their NI stroke scale score was before they got TPA, what time they got the TPA and what the dose was, and then how their vital signs, blood pressure, and that sort of thing are doing, and if they've made any improvement. Then also questions about blood thinners and things like that, aspirin, Plavix, you know, what kinds of medications and what their past medical history is to try to get an idea of what the cause of the stroke was. Now, some hospitals in our state actually have CT angiography, and we'll go ahead and get a CT angiogram of the neck and the brain so we can say where the blood clot is, if there is a blood clot there, because if they don't see a blood clot, then they could go to a hospital that treats post-TPA but doesn't have a thrombectomy capability. But if they have a large clot in a major artery of their brain, then they should go to a thrombectomy center. So those types of questions that we ask. And then also when they're transferred, there's a report of the nurse to the transferring nurse if it's by helicopter, or the EMS if it's by ground.
Are any of your pre-hospital providers using any of the available scales to evaluate for LVOs?
There are a number of scales that can be used, and the data is really out at this point is what is the best scale. I think the best thing is if there is a positive sign, that is you see a hyperdense middle cerebral artery or basilar artery or vertebral artery sign, and you have an NI stroke scale score that's greater than 6. And then I also personally will look if there's cortical findings that make me think it could be an embolic stroke or a large vessel stroke. But right now, there's a variety of scales that are out there, but none of them really have the sensitivity and specificity that I can recommend on a webinar to use.
Great. I think that's all the questions I have in the Q&A section. Go ahead.
I was just going to say we're getting ready to pilot doing telemedicine in the back of an ambulance. And we're doing it in Southwest Arkansas so that we can connect our neurologist into the back of the ambulance with the paramedic and the patient. And so we're really hoping that if this does work, that will really help us with the issue that you just described. Right now, we're really recommending for all of our patients to go to the closest stroke-ready hospital and then be assessed by a neurologist and then go from there, rather than trying to identify an LVO on their own.
Would anybody like to come off mute with *6 to ask a question? I think we're coming to the end of our time. Dr. Tremwell and Renee, I just want to thank you. I caught that you have your conference this week, so I appreciate you taking the time to do this webinar as you're probably also preparing for that. So we really appreciate that. And thank you everyone who attended. Again, look for an email in about a week from today with slides, a link to the recording, and your participation certificate. Thank you so much. Have a great week.
Thank you.
Thank you.